Okay. Hi, good evening, everyone. Welcome back to another webinar by Dr. Chia. I'm Dr. Betty, of course, for Beating Hearts. As you may know, we have a new website. Please subscribe to the website, and all registration for new upcoming webinar will be from the website. It also helps me because I don't have to send the link individually. So it is my work a little bit, but we have some teething problem. Just message me if you can't get in or something. Okay, we will sort it out. So, hi, Chia, how are you? Busy
I'm
day as
okay.
usual.
Yeah, and bad
Well,
weather. Mm,
and bad weather at the wrong time.
yeah.
When it rains, when people want to go and do the bazaar Ramadan, and then I'm so glad I don't have to face. By the time it rains, I'm already taking my afternoon nap. Okay, come, without further ado, come, let's do it.
Okay, sure. Okay, let me share. Okay, so we are going to start now, yeah? So, okay, so tonight I think we are going to continue the webinar on spondyloarthritis, but today we are going to talk about a different part, ankylosing spondylitis or axial spondyloarthritis. So first and foremost, as usual, we'll start off with a simple case scenario. Okay, just imagine if this is a case that actually comes to your clinic, 40 years old male and presented to your clinic for back pain. Okay, so what questions would you like to ask? So unfortunately, I think we can't have a live response this round.
We
Okay,
can, you can
can.
put in the chat.
Oh, where is the chat?
Chat is at the bottom here. You see at the where you share. Okay. And then next to it, there's a chat. So anybody, what are the questions you like to ask?
Yeah. So
Gopi, I saw Gopi coming in. Any
okay.
questions? Okay.
So of course,
Me start lah. Of course,
uh,
duration.
yeah, duration, that's good. Whether or not this is acute or chronic back pain, yeah. Oh yeah, I can see the chart. Does the pain wake you up at night? This guy is good. Yeah, type of
Oh,
pain.
of course.
Yes. Onset, yeah. Site, you need to know what is where is the actual site. Yes, what worsened the pain?
Yeah,
Very good.
very
Oh,
good. Very what wasn't the
very
pain?
clever people here.
Of course, they are my.
What are the what are the aggravated and relieving factor? So is it worse with movement? Is it worse with rest? Yeah. Is it responding to NSAIDs? Yeah. And of course, you need to ask associated symptom. Yes, may think
Good.
good fever, weight loss, constitutional symptom, any other joint
Numbness or
pain,
shooting pains to rule
morning
out yes.
stiffness, yeah, leg numbness, weakness, of course, bowel and urinary incontinence. Wow, very good. Very good start.
Oh,
Okay, so further questioning, this was his first episode, insidious onset, yeah. And then neck and lower back, yeah. And then more duration is important. Pain made better with movement. Interestingly, it's different from the other type of so-called pain. No fever, no night sweat, and weight loss, which are the constitutional symptom as mentioned. Yeah. And then so-called woke him up at night during midnight. But luckily there were no numbness, weakness, or urinary or bowel incontinence. So no red flags there. Okay, so
wait, chop.
yes.
Finally, the last time you shared us the clinical case with psoriatic arthritis
Yep.
was a male, and
Yep.
this time was a male. Is a male also, yeah.
Yeah.
Because I always felt that rheumatology is a disease of
Female.
female, but it's not true, huh?
Yeah, I mean, you are right to a certain extent.
Yeah.
I think God is relatively fair lah. They don't want women to suffer all the rheumatic disease alone lah. So men should share some burden. That's where this angst spawn comes about lah. Yeah.
Okay.
Okay, good thing. No history of trauma or fall. You need to know that. Okay, no cough or bowel symptom, no history of recurrent red eyes. Any idea why you need to ask for red eyes? If you remember the last.
Okay, I can. Okay, come on. Anyone? Don't give anyone with recurrent red eyes. Why?
Why?
Iritis.
Okay,
Okay.
uveitis.
I
Or
think
I think to be more specific will be uveitis.
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 How
Uveitis.
about the dry eye syndrome?
Sjogren. Zika syndrome. Not really, not really. But we
Okay.
are more interested on whether or not there's any inflammatory eye disease which is related to this spectrum of disease. Yeah.
Oh, I see. I never knew that. Okay, go on.
Anything in the history you would like to elicit? Of course, you want to know about the family history. And then it revealed that brother has psoriasis and chronic back pain. So this itself is a very actually giveaway point that you are dealing with something, not just a simple back pain. Social history is important because that will determine the person's long-term prognosis. For example, being a chronic smoker, married with 3 sons, what does it mean? What is the implication to his offspring? And his occupation, he is a heavy good vehicle driver. He needs to drive almost every day and more than 10 hours a day. So how does this disease actually impacted his so-called daily living? So this is very important in a holistic manner. Okay, so what are your thoughts on the back pain symptom? So I'm going to give you these 2 options. So do you think this back pain is more of a mechanical back pain or is more of an inflammatory back pain? Okay, come on, A or B?
Your B. Anyone? So much hint today.
Yeah lah.
Anyone? Come on. A
Who
or
is on?
B?
B. Okay
B,
lah,
okay.
someone already. Okay,
Eh?
A. Cannot lah. B. B. Is inflammatory back pain. Okay.
Okay,
So
what are the
inflammatory
example
back
of
pain. Yeah.
mechanical back pain? Maybe
So
you
what
can
are your
explain.
what? Okay, so then the next question I would like to ask you: how would you distinguish between mechanical and
Okay.
inflammatory back pain? So anyone come?
Mechanical back pain, okay? Maybe worse on exertion or movement.
Yes, correct. Because it's mechanical, you move more, you get more pain. Yeah, as compared to inflammatory back pain, is more towards resting pain. Yeah.
Okay, let me try another one.
Anything else?
Maybe there's a history of injury.
Yeah, correct. Mechanical back pain, likelihood there may or may not be some history of trauma. Okay. So basically the age of onset. So mechanical back pain can happen at any age, from as young as young children to as old as 100-year-old. And the onset is variable. Okay. And pain usually worsen with movement and improve with rest. Okay, as compared to inflammatory back pain, as you can see, the age of onset, we are looking at significantly, if let's say the onset is less than 45 years old. In fact, some literature suggested 40 years and below. And the onset is usually insidious, slow, progressive pain. Improves with exercise or movement, but does not improve with rest. In fact, what is the distinguishing feature of IBP is that the more you remain immobile, the more pain symptom or the stiffness symptom you experience. That is why they tend to have pain at night, which wake them up during the second half of the night. Yeah, make them feel very tired later in the morning. Other signs of inflammatory back pain to look out for: good response to NSAIDs. Remember, NSAIDs are non-steroidal anti-inflammatory drug. So if this is inflammatory in nature, that should respond to NSAID very, very well. Okay, alternating buttock pain is one of the features. So for those people who sit on the office chair, and then you notice that after now and then you feel the buttock pain, alternate buttock pain, you may need to think about that. Like I mentioned just now, waking them up during the second half of the night, and morning stiffness. Yeah. And usually the stiffness will last for more than 30 minutes after they wake up in the morning. Yeah. They feel very stiff. They feel like the whole back is like a robot, as stiff as a stick. And then only after more than 30 minutes, they'll feel better. And if let's say another distinguishing feature is if they take NSAIDs the night before, the next morning stiffness will miraculously disappear. That is also a telltale sign already. So physical examination will look into all these things, yeah, whether or not they are pale, whether or not there's red eyes, whether or not there is any skin rashes, okay? Because, for example, if the person has scaly skin lesions such as psoriasis, it also gives you a very direct answer already. Yeah, you look at all these cardiometabolic risk factor, because these type of diseases are actually closely associated with cardiometabolic disease. And then these are the things that you look for, okay? The gait, the peripheral joint, to see whether or not on top of the so-called the spine problem, there are also other joints involved. So what are the indicators of inflammatory back pain? Tenderness over the antithesis site. So where are the antithesis? Later I'll show you. Antithesis are mainly actually referring to the area where the tendons are attached to your bone. Example of antithesis will be your elbow, such as golfer elbow, tennis elbow. Yeah. So this will be the antithesis site. Another side it will be Achilles tendon, at the back of your heel. Yeah. So pain or tenderness over the sacroiliac joint, so-called the buttock pain, okay, or lumbar or thoracic spine. And they may tend to experience reduce in the range of movement of your spine, as well as loss of hip adduction, yeah, when you do the Faber test. So these are the things that we will elicit if a person comes to a rheumatology clinic with chronic back pain, suggesting for inflammatory back pain. We will try to look at the range of movement for thoracolumbar spine, for cervical spine. And another test that we normally do is called modified Schober test. Anyone heard of it before?
Oh, no. Anyone?
Betty, heard of it? Have
No,
you heard of it
sorry.
before?
No.
No. Okay, so
If I did,
basically
I forgot.
this is a test that is to elicit the so-called the extent of the spinal so-called the lumbar flexion. So how do we do it? We'll normally stand behind the patient and then mark the midline of at the level of posterior superior iliac spine, which is actually equate or corresponds to a place called dimple of Venus. If you look at your partner's spine, lower back, you can see two dimple there. Then that is the level that you should mark at the middle. Then after that, what you do is that you drew 2 marks 5 centimeter below from it and 10 centimeter above. Yeah. And then you ask the patient, okay, this will be the mark that we do. Yeah. And then after that, you ask the patient to flex, okay, bend down with the so-called make sure they don't bend their knee and also the hip. Yeah. So and then measure the so-called expansion of the so-called measurement. The usual so-called expansion should be anything above 5 centimeter. Any reduction of expansion which is less than 5 centimeter is considered positive sign. So this is a modified Schober test. It's not diagnostic, but it is a supportive test. So again, mark the midline at the posterior superior iliac spine, 2 marks, 1 5 centimeter and 10 centimeter above. Then after that, you ask the patient to bend down. Okay, this will be the modified Schober's test. So what are the investigations that we will do? Okay, usual counts. We will look at the so-called full blood count to look for evidence of chronicity, such as low HB. Yeah, we look at the renal profile because this patient may have been taking chronic NSAID. Remember, Ponstan did well for him. And then liver, okay, ESR and CRP, which are the inflammatory marker that we will look at. To look at this patient, both ESR and CRP were elevated. Okay. Then the X-ray, why we do X-ray? Because sometimes this condition will be associated with so-called scarring or fibrosis of the lung. So this case, nothing, okay? Or on the cervical spine, what can you see here is that you notice that the cervical spine is very straight. There's no more curve, loss of cervical lordosis. Okay, same thing go to the lumbar spine where it's straight and it's loss of lumbar lordosis. But the important thing is this pelvic X-ray. Anyone can tell me what is the feature being shown in this pelvic X-ray? Because if I see this X-ray, I am very, very happy because I don't have to do further tests.
Okay, anyone? This is very important. The one in the pelvic. Okay, I got no idea. Anyone, please? Gopi? Everything Gopi. Calculite.
No calculate there.
Okay. Is there calcification?
Where?
I see it on the left on my
The lower part there. That one is not significant. Okay, concentrate on the sacroiliac joint. You know,
okay.
SI joint. The SI
See,
joint here.
so no, so far no one.
No one. Okay.
Hold
So
on, let me check Facebook and see. No.
okay. So you can see there are evidence of sacroiliitis because
Oh,
you
somebody said irregular or bilateral.
yes, bilateral sacroiliitis because you don't even see any so-called space along the sacroiliac joint. So, and it's sclerosed and it's actually fused. So basically, this is an established bilateral grade 4 sacroiliitis. So if
Can you use the pointer and show me, please?
pointer, laser pointer, I'm very old school. Can you see?
Oh, okay.
Yeah, these two. Yeah, these two will be the sacroiliac joint, but you see all these are obliterated and it's sclerosed. So it's grade 4 sacroiliitis. Okay. Okay, so next. So
Oh,
sacroiliitis. Okay, so what
but
happened is
somebody
that,
said fusion of
so what
sacroiliac
is the diagnosis?
ankylosing spondylosis.
Spondylitis. Yeah, so this is
Spondylitis.
equilibrium back pain, and yes, likelihood this is ankylosing spondylitis. So at this point of time, if you are the primary care doctor, what are your plans? What do you want to do for patient?
NSAID.
Okay, good point. Of course, NSAIDs, yes.
Oh my God, the first one. I want to ask you,
Hmm.
is the COX-2 inhibitor as useful in this type of patients?
Yeah, I mean to us, is regardless whether it's COX-1 ke COX-2 ke, I mean is a selective or non-selective cause. The important thing is that we tend to prefer long-acting NSAIDs over short-acting NSAIDs. The reason is very clear because we want to have that kind of sustained anti-inflammatory response. So NSAIDs. So
Okay.
of course, number 2 is physiotherapy. Yeah, you
Oh,
need to
somebody said
refer to
yes. But they did,
physiotherapy.
they
Sorry?
did, David and Meeting said refer to
NSAIDs and physio, refer
rheumatologist.
to, oh yeah, refer to rheumatologist. Thank you. Yeah.
No,
Refer to,
just now you just complained tired and busy.
but we need to see lah.
Yeah,
Okay.
yeah, yeah.
Because I can tell you why. Because there are a lot of times when they go to wrong place and then they got investigated in the wrong direction. It really spend a lot on them and
Yes.
then they go nowhere and they actually suffer a lot. Yeah, refer to us. We are generally very friendly. I can't say for all, but majority of us are friendly lah. Okay. So this comes to a concept of spondyloarthritis that we actually talk about during the last talk on psoriatic arthritis. So spondyloarthritis or SPA refers to an umbrella of term that refers to all these diseases: ankylosing spondylitis, psoriatic arthritis, uveitis, reactive arthritis, juvenile SPA, and those so-called IBD, inflammatory bowel disease related arthritis. So all these are actually sharing the same genetic profile, particularly HLA-B27 positivity. So that's why when we talk about psoriasis and psoriatic arthritis, you can't help it, but there may be actually features of axial spondyloarthritis such as angspon as well. And same thing also, some patients with angspon may have skin psoriasis. Yeah. So this is the so-called the concept of SPA. So concept of SPA, like I mentioned just now, it can be further developed, so-called subdivided into predominantly axial, meaning to say that from the spine as the predominant. Then you have ankylosing spondylitis and non-radiographic axial SPA. What is the difference between the two? Is basically the so-called the X-ray changes. If let's say the person has already established X-ray changes of ankylosing spondylitis, then they are ankylosing spondylitis. For example, the sacroiliitis. For example, if the lumbar X-ray or the vertebra has the features of angspon, such as corner inflammatory lesion. Whereas non-radiographic axial SPA is referring to those patients whereby they come in with during the early stage where there's no structural changes over the X-ray, but if you do the MRI, we can see flare-up or inflammation signal along the MRI. So this is called non-radiographic axial SPA. Then you have the predominantly peripheral SPA, meaning to say that they attack mainly the peripheral joint. Reactive arthritis, psoriatic arthritis, the one that we mentioned last month, inflammatory bowel disease related arthritis such as Crohn's and ulcerative colitis related arthritis, and this undifferentiated SPA as well. So axial and peripheral SPA. Okay, so this classification criteria has come about quite a couple of years ago, more than 10 years ago. So how you classify them to have spondyloarthritis? So basically, you need to look at the patients if, let's say, they were to have more than 3 months history of chronic back pain, and the age of onset usually is below 40 or 45 years old. And then if, let's say, you have sacroiliitis on the imaging, plus one of the SPA feature from IBP, arthritis, enthesitis, uveitis, and blah, 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 race, CRP, good family history, good response to X-ray, and states. Or if, let's say, they have HLA-B27 positive, but no sacroiliitis on the imaging, but you need 2 feature. Yeah, so either one will do. Okay, so this is how we actually classify axial spondyloarthritis. Okay, so again, this is how we diagnose when we look at the symptom. Inflammatory back pain, sometimes they may have peripheral joint, they may have skin, they may have uveitis. Imaging, you look at the X-ray to look for sacroiliitis, and MRI, they look for evidence of bone marrow edema. Then ESR and CRP will be raised most of the time, but do not rule out inflammatory back pain just because their ESR and CRP are normal. Up to 50% of them, they have normal ESR CRP. So actually, they are very sad because they're being brushed off, and they're being so-called brushed off by some doctors thinking that it's not inflammatory. But when you do the MRI, hula, all the bone marrow edema and all the signals are there.
Oh, they have bone marrow edema.
Later I'll show you.
Okay.
So these are the terminology that we'll talk about. Like for example, dactylitis, meaning to say that sausage finger or sausage toe, the whole digit is inflamed. They tend to happen in psoriatic arthritis, but they do happen in axial SPA as well. Enthesitis, like what I mentioned, is the site where the tendon is attached to the bone. So where this is inflamed because of immune response, then they'll get a lot of pain and or swelling over the area, such as Achilles tendonitis. Okay, so this is enthesitis. Uveitis will be the inflammation of the eye, give rise to the kind of eye inflammation, and then red eyes and blurring of vision. Okay, so this will be the terminology to refer to when they actually look at the imaging. For example, ankylosis, meaning to say the fusion of the cartilage or bone, fibrocartilage, that they form the whole straight line fusion. Syndesmophyte are actually referring to the bony bridges between the 2 vertebrae. So what is the difference between the syndesmophyte and osteophyte? Okay, the elderly people like us, we tend to get osteophyte on our spine. What's so-called the bony spur. What's the difference? The difference is that osteophyte actually grows sideways. Syndesmophyte actually grow up and down. Okay, so that's the difference between the two. And then when they continue to grow, then you actually fuse the whole spine. And then okay, so give rise to the so-called the typical picture of bamboo spine. Yeah, so this is why it's called bamboo spine, because of the fusion or the syndesmophyte formation fusing along the vertebra. Yeah, unfortunately, these changes are irreversible. Once it's established, the spine is actually very limited. You can see the patients walk like a robot. Yeah, they can't really bend their spine. They can't really bend their neck. Yeah. So that is the importance of so-called early treatment and early detection. So ankylosing spondylitis is the commonest axial SPA. Okay, so it's a primary inflammatory joint pain affecting the axial skeleton. It will cause progressive limitation of spine mobility, and sometimes it may lead to peripheral joint involvement. Strong association with HLA-B27 genetic profile. Up to 90% of the axial SPA patient will have HLA-B27 positivity. Another 10% will tend to be negative, and that tend to be ladies or women. Yeah, and 2 to 3 times more common in men. So as mentioned just now, God is relatively fair lah. Give this to the men rather than women, everything lah. So Betty don't have to be upset. Okay.
Feminist in me. Okay.
So why is it important to detect and treat the inflammatory back pain such as axial SPA early? Okay, why? Because it's treatable. All right. Just like your cardiovascular disease, if you treat them early, they don't develop complication, they don't go into stage 4, stage 3, stage 4 heart failure, irreversible. So early diagnosis and treatment will prevent structural damage and prevent permanent functional disability. So if you anyone who have actually studied this textbook of Apley's orthopedic when they were medical students should be able to remember this. Okay, this is a hallmark picture showing the progressive deformity due to axial spondyloarthritis or ankylosing spondylitis. You can see the person actually will progress until the end of their his life, and then he succumb. Yeah. So what happened is that first stage will be loss of lordosis and atrophy of the buttock, then accentuated of the thoracic kyphosis, forward stoop if the cervical spine involved, and flexion contracture of the, and then with the compensatory knee flexion. So this will be the typical early feature, not to say early, it's actually already, where you can have that kind of contracture will try to compensate back by flexing the knee. And this will be the sad state if I still get these patients who come to my clinic. So when they have established ankylosing along the spine, including the neck, they can't even actually lift up their head and look at the sun. Actually very sad, and nothing surgical can repair it. None of it can be done.
Nothing, even a brace.
Okay, so the difference between the term ankylosing spondylitis and the axial spondyloarthritis is that during the 80s, when this criteria came out, so it looked at the clinical criteria. They have to have lower back pain of more than 3 months. They must have limitation of motion of a lumbar spine, blah, blah, blah. They must have limitation of chest separation. But the problem with this old criteria is that they actually insist on radiological criterion, which is a sacroiliitis grade 2 bilaterally or grade 3 or 4 unilaterally. So that's why during the early stage, before the so-called the ASAS criteria came out, a lot of diagnoses were delayed because because of this old criteria. Because now we know that once the X-ray changes have happened, is already actually established damage. And as we know, we don't want that kind of so-called permanent damage. Once the established structural damage has happened, it's irreversible. So as compared to this criteria from the ASAS, the spondyloarthritis criteria, it doesn't require that kind of stringent X-ray changes. So yeah, so it makes the diagnosis much earlier and faster. Yeah. Okay, so this has mentioned just now. Okay, so you see, when we look at the X-ray, what can we see from the X-ray in over the vertebra? You can see the shiny lesions we call sclerosis or corner inflammatory lesion along at the end plate there. Okay, and then you can start seeing syndesmophyte. You see the outgrow and downgrow of the spine. And then if you still do not do anything, do not treat, then everything will bridge together and then it will form a bamboo spine, bridging of the syndesmophyte.
Can I ask you something? When they actually form the bamboo spine, right? At that stage of disease, are they still having pain?
Yes. Okay, that is another thing that we would like to emphasize. Some doctors think that, oh, okay, it's already
Burnout.
No, there's no such thing as burnout, Betty.
Okay.
They are patient. They are still having inflammation. They still feel the stiffness. They still feel the pain. And you look at the inflammatory marker, they are still actually having evidence of high inflammatory marker. They're still worth treating. So when they're treated with biologics or those advanced therapy, they really feel a lot of difference, even though it may not improve or it may not normalize their range of spine movement. But in terms of pain, fatigue, discomfort, stiffness, it will go away.
Okay.
So you actually gain back some quality of life. So do not think that all these are burnout, because to me, there's no such thing as burnout until the patient die. Yeah. Okay,
Because
so,
when we were young, we were taught that rheumatoid arthritis has this burnout.
yeah. So we should actually forego this thing. Just like some old school thing that, oh, when you have SLE and lupus nephritis, when you already end-stage renal failure on dialysis, your SLE is burnout. That's nonsense. We still have SLE with dialysis. They still have active SLE, even though they are on dialysis. Yeah. So there's no such thing as burnout. Yeah.
Okay.
So this will be the sad state lor. If let's say you don't treat them well, they'll have all the feature of syndesmophyte, bamboo spine, yeah, and all this sacroiliitis already fills out. You can't see the thing. Same thing also, you can see the so-called the lesion there. Yeah. Okay, now talk about sacroiliitis. How do you grade if you are doing X-ray, and how do you grade it? So usually there are four gradings. Okay, grade one, if let's say you don't see anything, the so-called patient has features of inflammatory back pain from the history, yeah. But if you look at the pelvic X-ray, the so-called the sacroiliac joint, the space is still preserved. You don't see any erosion, but then you were a bit suspicious, a bit shiny at the corner there, yeah. So that is called suspicious. So the ideal scenario is that send this group of patients for MRI of the sacroiliac joint. Okay, you notice that why I talk about sacroiliac joint first, because most of the time for ankylosing spondylitis, the first joint involved will be sacroiliac joint, most of the time. But I can't deny that there were some patients who came in with neck first. Yeah. So but then rather than lower back. Yeah. So but most of the time we will concentrate on the sacroiliac joint. Then grade 2, when you start seeing some erosion, yeah, erosion, and then but the joint space is generally still preserved. Okay, so like for example, so this is grade 1, this is grade 2. So the minimal erosion and sclerosis, but the joint space is still preserved. Now, but then when you have grade 3, okay, the erosion and sclerosis is more clearly seen, and the joint space is already narrow. You can't see the very good line there over the sacroiliac joint already. Yeah. And then this will be the grade 4 sacroiliitis. The whole SI joint will be obliterated. Yeah. So this is grade 4 sacroiliitis. Okay, MRI. MRI is very useful nowadays. To me, is one of the important tools that I do to pick up early spondyloarthritis, particularly those non-radiographic type. Those that you don't see anything on X-ray, but then you can detect something that is not seen in the so-called X-ray. Then that also gives rise to the concept of non-radiographic axial SPA. Yeah. What are the findings? You have a corner inflammatory lesion and bone marrow edema. Okay, for example, if you look at the X-ray at the middle, you can see a very shiny corner, but you're not sure. But when you do the MRI sequence, you see the end plate here is actually shiny. Yeah.
Oh,
So this is called a corner inflammatory lesion or Romanos lesion. Yeah. Okay.
is it
Then
pathognomonic?
is yes, it is actually. But again, you need to actually have a good radiologist who is well versed in musculoskeletal radiology to pick up some of the small lesion. Sometimes the lesion can be very minute and that it may be missed lah.
I see. But
Uh,
this is obvious lah.
yeah, and this one, if I see this one, I'm very excited because it's already so-called crime solved lah. So MRI, you can see the sacroiliitis, you can see the bone marrow edema is hyper intense here. So basically these areas are all shiny. So hyper intensity. Then there will be bone marrow edema, erosion, fatty infiltration is when the so-called the structural lesion has happened. Okay, you start with bone marrow edema, then erosion. Then after that, the ongoing inflammation will lead to the damage and then infiltrated with fatty tissue. Yeah, so this will be very important for us to pick up early angspon or early spondyloarthritis.
I never thought of MRI imaging, MRI to look at bone structure.
Yeah, we do. I mean, this is
Yeah.
one
I
I do.
always thought it's soft tissue, useful for soft tissue.
No, it is
Yes.
very useful. Yes. Okay, so so this screening tool. Okay, so it's important for us to determine the nature of back pain, especially if you're sitting in a primary care level. Yeah, because if you're able to pick up, distinguish between inflammatory and mechanical. So this is a very simple inflammatory back pain assessment. Just 5 questions to ask. Number 1, did your back pain start when you are age 40 and under? Okay. Number 2, did your back pain develop gradually? Number 3, does your back pain improve with exercise? Number 4, do you find there's no improvement in your back pain when you rest? And number 5, do you suffer back pain at night which improves upon getting up? So if you were to get 4 or more out of this parameter, then it's likelihood inflammatory back pain than mechanical. So it should be further investigated. So this will be a very simple, primary care level inflammatory back pain screening tool. Yeah, it's available online. Okay, so so what are the so-called investigation you would like to do? Of course, after you do a physical examination, you would like to look at the counts, the liver profile, the renal profile, inflammatory marker. What about HLA-B27? Do we send it routinely? It actually depends, okay? Because it depends on your resources. Yeah, if your area has not such resource, then it's a bit difficult.
Is it very expensive?
It's around 600 ringgit.
Okay.
Yeah. Another thing is it necessary? If let's say you have patients who have established inflammatory back pain and you do the sacroiliac X-ray, is already show clear-cut sacroiliitis, then the question is, what will it add if you do HLA-B27?
Yeah.
Yeah, so I think it's individualized, individualized. Okay, so imaging, of course, we will try to concentrate on pelvis first, followed by cervical, lumbosacral, yeah, chest X-ray to look for fibrosis, and then please refer to rheumatology clinic. But then you also have to watch out for red flag sign, because not all inflammatory back pains are eng-spawn. Okay, why? Because you need to watch out for features such as prolonged fever, progressive weight loss, night sweat, prolonged cough, and neurological symptom. Okay, you know why? Because malignancy, especially if the elderly, okay, and infection, TB, which is still very, very, very common in our area. So this will be the red flag signs you need to actually pick up before you straight away label them as ankylosing spondylitis. Okay. Treatment, again, non-pharmacological, which include physiotherapy, is important to teach them how to strengthen the paraspinal muscle to prevent atrophy of the muscle. Education, you need to educate the patient on the nature of the disease. This is a long-standing disease. It's not something that can actually be cured. Unfortunately, there's no word cure for this disease. Yeah, the family members also need to be educated. Yeah. Pharmacological, of course, NSAIDs. After a good 1 month of NSAID, if the response is not better, or if the patient develops side effect to NSAID, or if the patient flare up after NSAID is stopped, then you need to actually start on with DMARDs. Okay, what are the treatment aims? Of course, you want to control the inflammation, because this is the thing that will actually progressively damage the joint. And again, I must emphasize the importance of it, because once the joints are damaged, it is irreversible. Yeah, of course, prevention of progressive structural damage, preserve the function, and allow them to maintain their social participation, their work, their family life, and so on. Pharmacological, of course, NSAID relieves pain and stiffness. And then the most important thing is reduce progression of structural damage because of anti-inflammatory property.
Oh, I see. It does also, huh?
Yeah, so I always tell my patients on eng-spawn, especially during the initial stage where I prescribe them with a course of NSAID. Take the NSAID regardless whether you feel the pain or not, because I don't really bother how much pain you can tahan, but I want the inflammation to be under control. Yeah, unless if you do have issues of NSAID-related toxicity or side effect. Yeah, and remember to use anti-inflammatory dosages. For example, if you are using celecoxib, you should use 200 milligram BD, not daily. If you use atoricoxib, you should use 90 milligram rather than 60 milligram. Okay, if you use meloxicam, you should use 15 milligram rather than 7.5 milligram, because you want it as an anti-inflammatory dosage. Okay, and you prefer long-acting over short-acting, as mentioned during the beginning. And continuous versus on-demand, again, this is a bit controversial. I tend to be on the continuous side, but there are my colleagues who actually opted on-demand option. Because of the concern, obviously, GI toxicity, renal toxicity, and as you know, Betty, cardiac risk, particularly certain NSAIDs such as etoricoxib, they are not very cardiac safe. Yeah. Okay,
Okay,
so
can you go back to just now the slide? There was a question that would you take it long term?
no. Okay, so the principle of treating angstpon during the first stage is NSAID for not more than a month. Two NSAID can be used. Two NSAID can be used within this period of 1 month. Meaning to say that if you try the first NSAID A for 2 weeks, then if let's say after 2 weeks you don't see much improvement, then you try to switch to another NSAID. The aim is to see whether or not the angstpon activity will become quiet after a course of NSAID for 1 month. After 1 month, if it fails to actually achieve that target, i.e. the patient still remains symptomatic, inflammatory back pain symptom, high ESR, CRP, or even develop toxicity, then you should move to the next step, which are biologic DMARDs or advanced therapy. During the olden days, the guideline was actually saying that it can go up to 3 months, but we all know that 3 months of NSAID, the kidney doctor or the GI doctor or the cardiologist will come and kill us. Yeah. So now the current guideline says that it's not more than 1 month. Yeah. So after 1 month of NSAIDs, if they do not see good response or because of the adverse reaction, then they should move to biologic DMARDs. But honestly speaking, in the patients that I see, if let's say they come to me an active disease state and they have a lot of poor prognostic factor, I will not even bother to go through the first stage. I will actually advise them to go through the so-called advanced therapy, which are biologic DMARDs. Yeah? So this will be the option that we should use. You have anti-TNF, you have IL-17 inhibitor, and then, sorry, actually JAK inhibitor doesn't belong to biologic, but is considered as an advanced therapy called small molecule. So this group of medications, biologics and JAK inhibitor, have been proven to be effective in actually disease control, putting the angstpon in remission. Okay, so it is effective in halting the disease progression and damage, but again, good things come with a price of cost. Okay, and then another thing is infection, particularly TB in anti-TNFs, as well as shingles in JAK inhibitor. Yeah, so this will be the concern. So what about those conventional synthetic DMARDs? You know, our good old methotrexate, sulfasalazine, blah, blah, blah. Do they really have a role? Honestly, no. When you have angstpon or axial spondyloarthritis, all these do not work. Some benefit or with sulfasalazine, but if let's say they involve peripheral joint, but if it's just a purely spine, no, don't bother putting them on all these conventional synthetic DMARDs because it will never work. Yeah. Okay, so I'm coming to an end already. So again, when it comes to inflammatory back pain, it's actually vigilant in identifying early feature of inflammatory back pain, because if you don't know what to see, you don't know, your mind doesn't know if your eyes don't see. Yeah. So your eye don't see if what the mind doesn't know. Then prevention of permanent damages and functional loss is the utmost important aim. So simple initial assessment, such as like I mentioned just now, the ASAS inflammatory back pain assessment tool is simple enough for you to get the kind of early diagnosis. Okay, NSAIDs is still the mainstay treatment, but again, we must use with caution. Okay, beware of toxicities. Okay, and please refer to us whenever you are in doubt. Okay, so that we can come to a more conclusive diagnosis. I think I'm done actually, Patty.
Okay. There is a question which I find it quite interesting because can you hear me?
Yes.
Okay. I find it interesting because I find that a lot of chiropractor is mushrooming up everywhere. So this person asked, will chiropractor help?
Okay, if this is a pure angstpon, if this is an inflammatory arthritis, honestly speaking, chiropractor doesn't help. In fact, sometimes it can worsen, it can make the condition worse. Yeah, because you chiropractic medicine basically involves the so-called manipulation or a realignment of the spine was and condition. But remember that is mainly for mechanical back pain, not inflammatory back pain. Whatever the chiropractor does, it will not actually control or get the inflammation better. In fact, it will make things worse.
Okay, the other thing is, somebody asked whether steroid will help.
Okay, in Angstborn, we do not advocate the usage of steroid, but of course, there are patients who, there are practitioners who give a course of steroid to relieve the inflammation. But no, according to the guidelines, steroids are not meant for Angstborn or axial.
Okay, Dr. Yuan Seng Kao.
Mm.
What are the specific physio referrals that are beneficial for back
Okay.
strengthening, back stretches?
Yes, yes. These are the exercise that you would like to ask them to do, such as the concentrating on the paraspinal, paraspinal, more towards stretching and strengthening. Try to prevent the so-called the paraspinal muscle atrophy. There are steps to be done. I mean, there are pamphlets you can see, because there are certain steps like for learn how to arch or learn how to raise up the leg and all these things. So there are actually some steps the patient can do regularly at home to improve, to help to maintain their so-called agility, the spine agility.
How about exercising or yoga?
I'm not very well versed with yoga, honestly, but I suppose if let's say anything which is closely resemblance to those physiotherapy sessions that I mentioned just now, the one that will help with the paraspinal muscle, it should be helpful.
Okay. Dr. Pon Seng Teng asked, what if patients no case of CKD or heart issues? What is the alternate treatment for them?
Yeah, good question. This is a real life thing, isn't it? Because life is not always happy and dandy. You have the elderly patient lah with CKD stage 3 lah and a chronic heart failure lah. Are you going to give them NSAID and make them die faster?
The COX-2 inhibitor.
No lah. I mean, honestly speaking, even COX-2 also, they are renal toxic. They are not actually renal friendly. I mean, it may be cardio friendly, such as celecoxib, but then they are not renal friendly. So in this type of patients, we will need to actually talk to the family and talk to the patient and what is their expectation. Okay, because if their angstborn is still active and they are so miserable, I will advise them to go straight to biologic therapy, because biologic therapies are generally safe even with patients with CKD or heart failure, provided you are not NYHA class 3 and below, whereby anti-TNF may be contraindicated. So IL-17 is a good option. Yeah, IL-17 inhibitor such as isacizumab and secukinumab, they are very good with angstborn. Yeah, so if they can afford it, they have their angstborn is very active. Even patient with CKD or heart failure, they still can go for biologic therapy.
Okay, can I ask you, do you mind reading the other questions then?
Okay,
Sophia?
I'm trying to look through. Okay, does deep needling helps in AS? The answer is no. It may help with relieving the pain, just like those acupuncture, but then it does not make your inflammation go away. Yeah. How about steroid in treatment? I mentioned just now, for axial, it shouldn't be used routinely. Genetic transmission rate to offspring. Is there will be higher association if let's say a person, if let's say the person is confirmed to be HLA-B27 positive, so the chances of passing to the offspring is around 50-50, because either from the father or from the mother, yeah. And like I do have good example whereby I have a family tree where 3 siblings are all angstborn under my follow-up, 2 of them on biologic. I have one mother who is angstborn after the son was diagnosed angstborn, and then both of them are biologic. So yeah, there is a genetic transmission. Yes.
Because of
share my
Okay.
screen. Oh,
Okay,
NATO.
okay.
Okay.
Okay, we will speak about that later lah.
Mm,
I will
mm, mm,
ask Dr. Chia to kindly share his slide, the PDF, and then I will share in the group chat. Yeah.
Okay. Okay.
Um, Good.
Anything else? I think that's
Anything else?
if
Last
still
one.
not settle this problem, proceed or with op or no need. This was the previous question. What do you mean by if still not settle this problem, will proceed with op or no need?
We
Okay,
already
so
mentioned that
if
operation that will not help.
surgery actually doesn't help, to be honest. Unless if let's say the patients with established end-spawn and then they already develop bamboo spine and then they develop osteoporotic fracture. You know, these patients are prone to get osteoporotic fracture. So if they do get that, sometimes what happens is that the spine surgeon may insert the so-called spine so-called the rod to stabilize the spine. Yeah.
But this osteoporosis, right?
Mm.
Do you treat them on a regular basis?
If they are confirmed osteoporosis, yes, they should be treated with anti-osteoporotic treatment as per protocol. Either anti-resorptive such as denosumab or adalimumab if they prefer orally, or if let's say even if let's say the severe osteoporosis, they may want to consider teriparatide. Yeah.
I see. So they are more prone because you said they are less than 40 years old when they get the disease. So that is
But
already
then,
right?
you remember this is an ongoing inflammation of the spine. So when there's inflammation, they will induce a demineralization. Then they will cause osteopenia and lead to osteoporosis. Yeah. And the problem with osteoporosis in axial spine is that, remember the bamboo spine? If you do the BMD on the so-called the bamboo spine, they will give you a false reading.
Is it because of calcification?
Yes. So normally we will try to avoid the spine as for the BMD reading, we will try to go for the hip and also the distal radius.
Oh, so you
Uh,
actually do it elsewhere, but the osteoporosis, is it localized or is it general?
no, Betty, it's a systemic skeletal disease. Hiya.
Sorry, I've got
Yeah.
no osteoporosis. I just checked. So Dr.
Good for you.
Siu asked, how long should the patient be on
Good question, because when you start the patient on biologic, the patient asks you, how long should I take it? Because it's about cost, isn't it? It's still very expensive drug. There's no clear-cut guideline to say how long, but then the aim is to keep the disease in sustained remission. I use the word sustained remission, which is extrapolated from rheumatoid arthritis, whereby if the patient achieve remission continuously for 2 years and beyond. So I will tell my patient, if you want to treat properly, make your disease in remission long enough, at least 2 years, then we'll start to taper the medication biologic either by reducing the dose or increasing the gap. So far, I have two patients whom I managed to stop the biologic after they have completed 2-3 years of biologic, and then they actually increase the gap beyond 6 months, and then they still do not have any attack. Then we decided to stop it. There's still a chance of stopping it lah.
You know, my dog has osteoarthritis, and I put him on
Your dog is quite elderly, I think.
yeah, Gallipran, 12 ringgit a day,
Wow. What medication was that?
Gallipran, Gallipran. And
12
I looked it up. It's only for dogs only.
No, it's only for dog. I don't have never heard
Yeah,
it
I
for.
never heard of it before. I also Googled, and they didn't have stock, and we stopped for a while, and he couldn't stand up at all, Wow, so sakit hati, I went and buy some more.
Can ankylosing have any association with mixed connective tissue disease? To be honest, Dr. Swaran, is a bit unlikely or unusual. If let's say the person have MCTD with Angstborn, then I would say that he or she is very suay.
Sure.
They don't share the same genetic linkage, or to be honest. Yeah.
This mixed connective tissue disease, we need to know more, lah. Maybe the next time.
The one is very complicated.
Yeah, that's right. That's why we need to know more.
You are looking at the jumble of different autoimmune disease in a pot, you know.
Yeah.
SLE plus myositis, SLE plus scleroderma, all these things are, so
Yeah.
it's,
So one day,
yeah. Mhm.
okay. Thanks, everyone.
Yeah,
We'll stop here.
yeah,
And
great.
please subscribe to Beating Heart's website. And also, we will try to get your e-cert ready as soon as possible. Have a
Mm.
nice day.